So with urinary retention, just think that urine is retained in the bladder and it can't get out. And in urinary incontinence is the exact opposite. You can't hold urine in with incontinence, so it spills out. Now for urinary retention, the causes are simple, like after surgery, post-op, after a Foley that is discontinued, and even men with BPH, that benign prostatic hyperplasia. So just think BPH is a big prostate that holds back urine. Half of the men over 60 have this, so it's very common. HESI question even mentions a patient most at risk for urinary retention is a 65-year-old man with that benign prostatic hyperplasia. Now, certain medications can also cause retention, like in opioids that make the body low and slow. So we get low vital signs and slow bowels, as well as slow urinary output. Drugs like morphine and hydromorphone, including others. So just look for the O's for the opioids. Think that low and slow body. And anticholinergics is another big culprit. So for anticholinergics, just think anti-secretions. So the clients get really dry. You can't see, can't pee, can't spit, and can't poop. So ipratropium is a respiratory drug, so just think you can't pee with atropium. And atropine is another anticholinergic, used to increase the heart rate, so just think it's hard to pee with atropine. And lastly, tricyclic antidepressants can also cause urinary retention. Now, as far as nursing care, assessment always comes first. So with any abdominal assessment, we always look first, listen, and then feel or palpate the bladder. Then we do interventions if the client still cannot void after surgery, which is very common. We always try least invasive measures first, and then we use instruments. So in this order, number 1, we use normal positioning by helping the client out of bed. Then number 2, we use a bladder scanner if unsuccessful. And a key term here, over 100 mLs, we must report to the HCP. This is priority, since the provider will have to order an in and out catheter, aka intermittent catheter, and again, this is always done last. Now caution, it's priority to watch for hypotension, that low blood pressure, and bradycardia, that slow heart rate. Just think about the client here. They're getting immediate relief with a catheter, kind of like floodgates are opening up. This rapid bladder decompression can provide much relief and relax the body too much, making the vital signs low and slow. Now, common NCLEX questions. Question number 1. Patient taking hydromorphone with urinary retention suspected. What's the first action? It's always assessment here. So, option 1, palpating the client's subpubic area is the assessment we do. Now, don't let the NCLEX trick you here. We always assess the patient first, not checking the chart for I's and O's. That was the most commonly chosen wrong answer. And not asking if they need to use a bedpan. This is an intervention. And if you chose option number 4, you nasty. Question number 2. Intervention for a patient who has not urinated 10 hours post-operative. So look for the keywords normal standing position. So the answer is to help the patient out of bed to a normal standing position. The key word here is intervention. So don't let the NCLEX trick you here. We want to do the least invasive measure first. So not the bladder scanner and not an in and out catheter first. Remember, machines are second here. These are done after standing up is unsuccessful. Now question number 3 here. Urgent catheterization for acute urinary retention. The nurse places priority on which sign and symptom. So before looking at the options, you're already thinking here, you're opening up the floodgates. So we're thinking that everything's going to be low and slow, nice and relaxed. So option 1 and 2 are correct. Bradycardia and hypotension, that low heart rate and low blood pressure. Out of all these options, these are the priorities here. The other options really kind of relate to infection. Now lastly, a side note on Foley catheters. We always want to keep the bag below the level of the bladder to drain via gravity. So never raise above that level. And never put on the back of a wheelchair. This can impair flow and lead to urinary retention as well as bladder distension. So Hesse mentioned this in 2 questions, asking which action by the UAP would prompt the nurse to intervene immediately. And the correct answer was lifting the bag above the patient in bed to drain the collection bag. And question number 2 was immediate intervention. And the correct answer was when you observe transport personnel hang a urinary collection bag on the back of the wheelchair. No, always below the client for proper drainage. And the last 2 points here. If you miss a catheter attempt, we always leave it in place and get a new kit. And a tricky question here, self-catheterizations at home. We teach clients clean technique, not sterile. So, sterile insertion isn't needed if the client is at home doing it themselves. So Hesse had a question stating, statements that reflect understanding for self-catheterization. And the answer is, I will use clean technique when catheterizing myself at home. Yes, the key term here is clean technique for self-caths at home. Now, Kaplan mentions a few key points here. A catheter is inserted into the vagina, not the urethra. What's the first action? And the answer is to leave the catheter in place and obtain a new catheter. And the first action for distended bladder and 20 mL of urine output in 2 hours via the catheter. And the answer is to inspect the catheter tubing. Yes, we always assess first. But this one's a little bit tricky because we assess the device here. So the question already states that the client has a distended bladder, indicating a physical assessment has already been completed. So always after the patient has been assessed, then we assess machines as well as equipment. So in any case, just let the questions help you here. Now switching gears here to urinary incontinence. Remember, you can't hold urine in with incontinence. Now there's 3 types, so let the name help you here. We have urge incontinence, which is the sudden urge to urinate from overactive bladder that randomly contracts involuntarily. It's kind of like a ticking time bomb, resulting in urine spilling out, typically known as neurogenic bladder, that loss of bladder control, caused by neuroconditions like spinal cord injury, stroke, and even Parkinson's. Now, stress incontinence is that pressure stress that causes urine to spill out, like coughing, laughing, sneezing, running, or even jumping. Now, this is very common during pregnancy as the baby is putting a lot of pressure on that bladder. But even older age, we get weaker muscles and loss of bladder control. Now, the last one here is overflow incontinence, where we get an overflow of urine in the bladder, which leads to dribbling of urine. This incomplete emptying results in urinary retention that stretches out the bladder and urine leaks out, commonly caused by urethra prolapse, as well as prostate enlargement, that BPH. The memory trick is BPH, a big prostate that holds back urine, as well as weak bladder muscles, like with our diabetic patients in diabetic neuropathy, or even spinal cord injury. We get that loss of bladder control. Now, Hesse had a lot to say about the patho and causes here. So, question 1, male reporting urine incontinence, ensure a prostate exam is performed. And question 2, stress incontinence cause, expected result of aging. And a select all that apply question here. The leakage of urine occurs in small amounts and is more frequent when the patient coughs. Which information does the nurse provide to the patient about the disorder? So let the question help you here. The key terms here is when the patient coughs. So this is called stress incontinence, and this is caused by weakness of muscles around the urethra, and this occurs when intra-abdominal pressure exceeds the urethra resistance. Now, the last question, an elderly female patient experiencing urinary incontinence, which physiological change does the nurse expect to see in the patient? And the answer is decreased muscle tone. Now, in regards to management of the condition, most test questions come from this section. So grab your pen and paper and be sure to write this down. I placed all these in order in terms of importance on the board exams. So number 1 overall is training of the bladder. And the key terms is void regularly every 2 hours. This is the highest priority on the NCLEX. Once again, the key terms, write it down: voiding regularly every 2 hours. This prevents UTI and skin breakdown by stopping that dribbling of urine. Always first here over the rest. Now, weight loss is the second most important here. It helps take pressure off the bladder and pelvic floor. And third, Kegel exercises 4 times a day to strengthen the pelvic floor muscles. And we always avoid caffeine, alcohol, and smoking, the bladder irritants. And lastly, anticholinergic meds, oxybutynine, to decrease the bladder spasms. So just think the B in butynine is B for bladder. Now, the big thing to write down about this is the dry mouth as a side effect. So this is an anticholinergic. So just think it's anti-secretions, which means no secretions, we have a dry body. But again, out of all these, the priority over all are voiding regularly every 2 hours. This was the most tested and most stressed for that stress incontinence. Now, a common NCLEX question: priority teaching for a patient newly diagnosed with that key term here, stress incontinence. Voiding every 2 hours. Remember, not Kegel exercises, not avoiding alcohol or caffeine, so don't let the NCLEX trick you here. Priority is always voiding pattern, voiding every 2 hours for stress incontinence. Now, we saw a lot of questions come from stress incontinence. So Kaplan mentions the first action for urinary habit training is to establish the client's voiding pattern. Remember, that's always first. And a 78-year-old client, 200 pounds with 4 live births, experiencing stress incontinence. The most appropriate statement by the nurse is, let's talk about ways to reduce your weight. Remember, that's always second, reduction of weight. And ATI mentions teaching for a client with a BMI of 32, newly diagnosed with stress incontinence. And the key teaching is to lose excess weight. And Hesse mentions a patient with stress incontinence. After birth of a second child, teach to perform Kegel exercises 4 times a day. And the second question was, considering the care plan information below, which condition is the patient most likely experiencing? So, when you're looking at the care plan info, look for the key terms here: Kegel exercises 4 times a day, and toilet every 2 hours. So the answer is urinary incontinence. Now, switching gears to urge incontinence, Hesse mentions which statement indicates urge incontinence. And the answer is, I never have enough time between when I first feel I need a void and when I'm incontinent. Remember, this is sudden involuntary, like a ticking time bomb. That sudden urge. Now, a common NCLEX question: the client understands self-care of urge incontinence with which statements? Select all that apply. So option number 1, I'm going to void only in the morning and the evening to ensure bladder training. No, we void every 2 hours. Remember, that regular schedule to train the bladder, not 2 times a day. The key term is every 2 hours. And option 2, it's okay to have moderate amounts of wine at night. No, we have to avoid alcohol as well as caffeine. And option 3, I understand that taking oxybutynine may result in a dry mouth. Yes, anticholinergics are anti-secretions, that dry mouth. And option 4 and 5 are incorrect. I understand that having excess weight is okay. No, weight loss is best. And I will limit my intake of coffee to only 3 cups a day. No, we want to avoid caffeine and alcohol completely almost. And lastly, I will do Kegel exercises every day. Yes, pelvic floor training daily. Now for overflow urinary incontinence, a common NCLEX question: nursing interventions for overflow urinary incontinence. So just think about the patho here. The bladder is overfilled, so we need to empty it with every void. So option number 1, teaching to bear down when voiding. Yes, this is done to empty the bladder fully. And option 2 is a big one. Teach to wait 30 seconds after voiding to try and void again. Yes, we need to try and fully empty an overfilled bladder. And 3 and 4, monitor for skin breakdown and record output. Yes, these last 2 are done with any incontinence really, where you can't keep that urine in. So we have a huge risk for skin breakdown from that dribbling of urine. And technically, we always record any output. And lastly, ask for overtime pay. No, not correct here. Well, it could be correct when you start getting your career, but not in terms of urinary incontinence. All right, guys, that wraps it up for this segment. Don't forget to take